We talked a little about this kinetic chain of pitching or throwing, and again, I sort of like to emphasize and think about the different stresses, because as I diagnose an athlete, and as therapists and as other doctors diagnose athletes, if you ask them carefully, you can determine where in this pitching phase that their pain occurs. And if you can determine where in the phase of throwing that occurs, you can often help dial in and diagnose or get your injury pattern more specific. Is it at the release? Is it at the follow-through? Remember, when the ball leaves the arm, your body has to decelerate this force, lest the arm fly off the body. And we really study this very carefully, and we think about all the nuances of throwing and looking at film and assessing 20 or 30 second shots, where the elbow is, where the shoulder is, where the foot is, and this kinetic chain, when it breaks down, when you have a bad ankle sprain and it breaks down and your elbow subsequently drops and you have shoulder pain, it all comes back and connects to another self again. Looking at elbow position and shoulder position and these sidearm pitchers, if I take this sidearm pitcher and actually really critically analyze his mechanics, he's just turning his whole torso sideways. So it's not necessarily his elbow that's dropped down so far below his body. But when younger kids emulate this in an incorrect fashion, they can end up with significant injuries. This is the crux of my talk, and I'm going to take one extra minute to sort of really think about this. This is an x-ray of an elbow. And on the top is the humerus, on this side is the ulna, and this is the radius. This is the lateral side, and this is the medial side. If we think about or really simplify, and perhaps, and I apologize, in oversimplified fashion, there's a couple of structures. There's the ligaments on the inside of the elbow, the medial collateral, the ulnar collateral, or the Tommy John ligament. Those are all really synonymous. What happens is this ligament gets stressed and pulled on. And on the lateral side of the elbow, compression occurs. So when really simplified, what we're seeing is stress and tension on the Tommy John ligament side and compression on the lateral side. And that will really help break us down into the basic injury patterns that I can see in throwing athletes' elbows. On the lateral side, again, since these are under compression, I'm going to see growth disturbances because the growth plates don't like being repetitively pounded. Dr. Vidazzi taught us about OCDs. I'm going to see repetitive stress injuries in OCDs on this side. The radial neck, while growing, can get malalignment issues, and there can be loose pieces of cartilage that fleck off from the repetitive compression on that side. What goes wrong? This is whether good or bad, a lot of my job in seeing what goes wrong and trying to repair it. Osteochondritis dissecans has been around forever. It's described in the 1500s, well articulated in 1888, and Dr. Panner helped us understand this disease, this OCD of the elbow from repetitive stress and overuse. This occurs in 8, 9, and 10-year-olds. The beauty of the Panner's disease is that when someone comes in and says, my young kid's elbow hurts, what should I do? And X-ray is the diagnosis and rest is the answer. And the overwhelming majorities of 8, 9, and 10-year-olds will get better from this. Unfortunately, when that doesn't happen and you push through this and rest is not an appropriate option, the OCD, the full-on OCD in 12, 13, and 16-year-olds can occur. And this is where the cartilage actually gets so hypovascular, the insult becomes so significant that it can fragment and actually break apart. This is a painful condition. Kids can't throw through this and often require surgery. Sometimes to try and put this back together, like Dr. Vidazzi described, sometimes to arthroscopically take out those fragments. The challenge is once this happens, the career of that 16-year-old is often compromised, and throwing on a high level is often not going to be an option. Going back to the compression and tension side, here's an elbow again. This is the Tommy John side of the ligament, right over here. And over here is where the tendons and muscles occur. Many kids will come in and say they have pain on the inside of their elbow, and we'll examine. They'll be tender in that area. If they continue to have tenderness, they can develop a stress fracture on the inside of the elbow. If you continue to play through that stress fracture, or at times a sentinel, very strong throw, that piece of bone can actually come off of where it belongs and displace. And now this ligament that lives in there is permanently injured and permanently shortened. For those individuals interested in playing baseball, we have to repair that. That means this 12-year-old has to have surgery in order to continue to play sports or have a normal functioning elbow. And that sometimes requires a pin. In this case, requires putting 2 screws in. We tend not to take these screws out if we don't have to, but sometimes they have to come out. That means a second surgery. Stress fractures in the olecranon, where we can see a normal growth plate, active throwing through a normal growth plate can cause issues, and we can see this on X-ray and MRI. The last part, and I'm just going to spend a few minutes talking about this, is the ulnar collateral ligament. Tommy John is who this is named after. This is his rookie card. And the surgery was named after Tommy John because he was the first person to have this surgery. It wasn't named after the doctor who did it. When we understand this or think about this a little carefully, the Tommy John, or the ulnar collateral ligament, is the strong band on the inside of the elbow, and there's a couple of different pieces of that ligament, but it's really one specific component of that ligament from repetitive overuse that gets injured. Here's a picture of Tommy John now showing off his scar. By the way, he had 2 surgeries. The first one didn't work, and he's currently a manager of a baseball team in Connecticut. The history is really what helps me on this. I examine athletes. They'll point to me. They'll determine that the inside or the medial side of their elbow is what hurts. There's a couple of structures over there, and I'll start to examine and palpate where it hurts. On this image over here, you can see I've drawn the bony prominence, or the medial epicondyle. Right attached to that is the muscles, the flexor muscles, and right underneath that is the ulnar nerve. And these are all issues and concerns that I'm going to have as I examine. A very useful test is what I call this moving valgus test. So I'll stabilize the elbow with my hand, and I'll take the elbow through a range of motion, putting stress on that. This is very, very diagnostic and useful, can help point right to a source of ligament. And that's when I say to the athlete, I'm worried. We need to get an MRI scan. In the absence of that, they all walk out smiling when I say, this is a tendonitis, this is an overuse, you're going to be okay. I want to examine and look at what's going on with the ulnar nerve. And sometimes that nerve, you see that little pop under my finger? That nerve can slide in and out of joint. And the nerve itself could just be a source of irritation. So examining the medial elbow, there's a lot to it, to tell you the truth. Finally, I want to look to see if there's pain or spurs in the back of the elbow. And as I gently bring the elbow into full extension, I can elicit whether or not the back of the elbow has spurs and is actually painful. X-rays are useful to help determine any kind of wear, and it's amazing as you look at some of the professional pitchers' elbows, the condition they're in and their ability to still pitch. MRI is the gold standard in determining whether or not this ligament is indeed injured, and the treatment options. We certainly want to look at everyone differently. Non-operative really doesn't work that well, but many kids don't want to go back to playing sports at that same level. So in a young athlete, in a 13 and 14 and 15-year-old, I think most of us are obliged intellectually to go through a non-operative course. At least that's what we do in the Greenwich Sports Medicine Service. Certainly you can find more aggressive surgeons more eager to perform surgery, but I do think this is something appropriate. Who do I fix? The 17 and older athletes who are college-bound, who have determined that they have the skill set and the desire to play at the next level and the commitment to, who have felt the acute pop, who have a complete tear on the MRI scan. I'm going to show you a couple pictures of surgery. It's almost impossible for me to talk about Tommy John surgery without mentioning Frank Jobe right here and Lou Yoakum. Those of you who follow baseball may know the names. Dr. Jobe invented Tommy John surgery, and when I asked him, I said, well, why didn't you name it after yourself? He said, well, I did it on Tommy John, so I think that's what I named it. Those of you, and Dr. Yoakum now probably does more of these than anyone in the world. I just recently did Strasbourg. These are the guys who taught me how, and they taught me the principles of how to examine an elbow and understand it, so I pay my allegiance. What happens here, in a cadaveric picture, I can see the ulnar collateral ligament, or at least the most relevant, important band of it. It's the anterior band, and that's what we're going to reconstruct. And this cartoon shows how, through drilling some bone tunnels and weaving a new ligament in there, we can recreate this Tommy John ligament. And here, everyone always asks, how do I get this? Where do I get it from? Most individuals will have an accessory ligament in their wrist, and that accessory ligament has been used for about 20 years with great success. So here, through 3 small harvest sites, or tiny harvest sites, how I get it, and that's what that ligament looks like. And that's what we're going to weave into that. Many individuals ask me, does this matter? Well, there's about 475 professional pitchers who are playing with this tendon removed from them without any difficulty. So I think now, fortunately, we can say that the data does support it. There are other sources when that ligament's not present. Sometimes we can go to the other arm. Sometimes you can go to the knee. We do this through a muscle splitting approach, so it's a reasonably small incision. We don't really have to cut any muscles. We split things aside. And here in this diagram, I show drilling holes so that I can weave this back in. And in this last picture, you can see the ligament weaved in, and here in real life, you can see a Tommy John reconstruction done. Post-operatively, patients are going to wear a splint for a few weeks. They're going to get into a physical therapy program. At 4 months, start throwing and return to really competitive pitching closer to 12 months. 9 to 12 is on there, but it's really closer to 12 months. It can be a potentially career-ending injury, but done properly, approximately 85% of throwers, and that includes the ones who attritionally drop out, about 85% can get back at a high level. People are very excited to show off their war wounds from this, and this is one of my favorite procedures to do because it really works quite well. And that's it for the shoulder and elbow.